Welcome everyone to those who join us in this 192 webinar for the Andean Health Regional Association, and we started in May 2020. Now we are celebrating 3.5 years of continual learning. In this fine occasion, it's a pleasure to share with you stigma and discrimination that stops our fight of HIV. The COVID-19 pandemic let us know that in these 3 years of multidisciplinary work, we need to keep fighting, maintaining health in the center of policies. And this is extremely important to have health in the center of policies of research, epidemiological surveillance, the development of vaccines and pharmacological products, promoting and preventing are extremely important for our society. Some reflections about those priorities and relevant priorities are found in the Bulletin Andean Health that is available in the website of the Andean Organization of Health. I would like to invite you to share with us in the chat box your name and the institution you belong to. In this same space, you can also put your questions or send them through an electronic mail to our main website. So in this webinar, we will start with the institutional welcoming words and then the presentation of our speakers. So then we can go to the Q&A session. To access your attendance certification, you can put in the Facebook Live or the YouTube channel, you can find a link where you can put your information, filling up some surveys to know your personal information, and email so we can send the certificate to your email in the following days. So to start with this important date, I would like to invite the secretary of our Andean Health Organization to give the opening remarks. Please, Doctora Calle. Good morning, everyone. I am broadcasting from Buenos Aires, Argentina. Right now we are in the World Summit of Mental Health. So we are now in the afternoon. And today for Peru is the Peruvian celebration for the Medicine Day. And of course, for our Andean brothers and sisters, it's important to value human medicine as a human-centered discipline, promoting the exercise of their rights, having access of health services with the highest quality standards, reaching everyone, especially the more vulnerable individuals. Very few infection diseases of human story have come with so much stigma such as HIV, but this is something that has to end. We now have the evidence of what is happening, so it's time now to move into action. The strategies for 2020-2030 of the WHO highlighted the fundamental role that we have in the health sector when we wanted to end up the epidemics. At the same time, adopting a multi-sectorial approach of every single policy making. In those strategies, it's recommended to include 5 important aspects. The first of them is to focus the health systems on people rights to promote integrated patient-centered approaches and link them with primary care health services. This is a key element to confront an epidemic. The second is to address the specific priorities that are required to be concrete. There are more than 40 years of global efforts in a world scale to increase resources, expand services, and address inequalities, backed by strong community participation. However, progress has been uneven. Much remains to be done in terms of access to services, protection laws. We need to emphasize the elimination of vertical transmission of HIV and addressing the specific needs of the children, involving more men into the response. And one aspect that needs to be given more attention is the reduction of HIV related deaths, which are still at unacceptable high levels. Here, of course, comorbidities become important, especially tuberculosis, and I will include also diabetes, to be prepared for emergencies such as those we had with COVID-19, the response to specific groups such as migrants, indigenous communities, or marginalized communities. The third strategy that is also included as a common approach to be reinforced are the community health systems that have to attend the needs of people, the families, and the communities. Here, the community plays a fundamental role in order to harmonize a timely response within a framework of rights and participation. A fourth aspect will be related to responding to a rapidly changing health and development context that is constantly changing. The COVID-19 pandemic has been a severe blow to global health. The President Fernandez, a couple of hours ago, said that this was a silent war without human resources, without financial resources, and put into evidence the deficiencies of health systems and has put into discovery the disparities that will provoke that some populations are more susceptible or more vulnerable to diseases in comparison with other populations whose access to services is severely hindered. And finally, and why we are here, to eliminate the stigmatization, the discrimination, and other structural obstacles. To achieve the 2030 goals, a major expansion of services is required, which will not be possible without initiatives to address the stigmatization, discrimination, inequalities, and criminalization of key populations that exacerbate their risk of infection and prevent their access to essential services. This strategy also contemplates that the health sector can play a fundamental role in addressing stigmatization, the discrimination, and political obstacles in healthcare, for example, by generating data on the effects of stigmatization and discrimination in the populational groups that are most affected by HIV. And that is the reason why we have organized this webinar, joining the effort that our countries are currently making. I don't want to overlook the recognition of those who started this process precisely to show evidence for action. The global network of people living with HIV, GNP+, the Positive Leadership Alliance and Key Population, and the Latin American Network of People with HIV, REDLAC. The Andean Organization of Health is the technical secretary of 6 ministries of health, and we have remained together for more than 51 years. There's a committee of HIV, AIDS, hepatitis, And there's a commitment with the authorities to generate, based on the evidence, a regional plan to eliminate the stigma and discrimination for what we consider an opportunity and a commitment. And during the early 2000, we negotiated some prices so antiretroviral therapy could be more affordable and be accessible to those populations. So our thanks to UNAIDS and the consortium Key Population Alliance, made up of 10 regional networks of people with HIV and key populations. With HIV receptor in, we were able to organize in Panama an event that tried to call the responsible authorities of all the participant countries, the United Nations, the Ombudsman Office, and the organized community, and where we agreed that it was essential to disseminate this result. Welcome and thank you for participating in this event.
Muchas gracias, doctora Calle.
Thank you so
Seguidamente,
much, Dr. Calle. And now I will give the word to Dr. Andrea Bocardi, the Director of NACID for Andean countries, for the institutional welcoming remarks.
Un gusto, un saludo, María Carmen.
Thank you, Maria Elena. My deepest gratitude and extending my regards to the colleagues in Buenos Aires. First of all, I would like to thank the joint efforts that we are always putting together with Horas Cono. This is our opportunity in this alliance with ALEP, the alliance of key populations, those people that represent those more the most affected communities in relation with HIV. We would like to thank you for the commitment and the efforts that you are conducting jointly to have at your disposition all this updated information that we're going to share with you. I would like to let you know that the subregional analysis of the discrimination indexes that are presented are from 5 Andean countries, are the ones that we established from the office. And we consider that this is a tool that will be extremely important not only for the incidents from the communities that will demand services without an stigma and discrimination in function of the current evidence, but also for the decision makers between policies and the different sectors of the response to HIV that are in charge of elaborating this program, that in base of the findings and the gaps, we can use also intervention that have shown to be efficient and have some impact in the elimination of the discrimination stigma, in this case in the health sector. Two messages. First of all, to invite you, as Maria del Carmen said, for every single community group and civil society, activists that are integrated to these efforts, that the actions as the strategy established this of AIDS needs to be centered in the community and led by the community. So due to this effort of collecting the information and the evidence has conducted from the community, I propose you to be integrated so every single country can be part of the roundtables that will define from the beginning the action plans for these different institutions that are involved. And of course, we can do it as a joint effort. I would like to mention also that with this information that is already available, we have some actions that we are conducting with some impact. One of them of having that distance or this instance that will allow us to use the information to update the subregional Andean plan, because this effort that Horas ONU is conducting has some years now. And the other one is that in every single one of our countries, we have opportunities of building on the efforts between the different stakeholders because we know that we are conducting some efforts, but we need the systematization so we can ensure to have a real impact with a change in the perception
que sufren las personas
of
viviendo
the self-stigma for those people that live with HIV and the key population that I want to name them.
¿verdad? Entonces es importante que
Because
entendamos
when we don't name and we don't name them, they do not exist. And of course, the key population will be defined by every country, but we have like a joint effort that have a high prevalence of HIV in every single country in this region
epidemias concentradas como son los hombres
that are concentrated epidemics, men who have sex with men, transgender women, sexual workers, users of drugs, and people that are inmates. We have at least two of these subregions that the migrants have some prevalences, have double prevalence of national base, and some indigenous communities that have higher prevalences. So here we have a huge group that where we can identify men, women, different groups that will need an approach. So I will invite you to join us from the countries of Ecuador and now Peru, that the Ministry of Justice has accepted to be part of the Global Alliance Against all the forms of discrimination around HIV, something that is showing the commitment to work together with the communities so we can establish a specific strategies because we have so many commitments already there. So thank you so much, and we will keep move forward to see the result. Thank you, Maria Elena, for the invitation. Thank you, Dr. Bacardi. We started with good news then. After these institutional welcoming remarks, my name is Maria Elena Villar. I am a physician responsible of hepatitis, HIV, AIDS in the Health and DN organization, and I will be leading this webinar. After these opening remarks, especially to introduce ourselves, and of course, we need to present the analysis of the Andean countries based on the index studies of the uh, discrimination and stigma. And I would like to present Dr. Alban, master degree in evaluation and administration of projects, candidate of PhD in development management and public policies. He has post-graduation studies in demography, economy, environmental evaluation, quantitative methods for the decision making, systems dynamics, finances, and others. Jorge Medrano was responsible for the monitoring of the component HIV/AIDS and infectious contagious diseases. He was also responsible of 4 rounds of bioconductual studies, and he has conducted as coordinator of different programs. He has more than 20 years of experience in the public and private areas and entities such as the Statistical Institute of Bolivia. He also worked in the Institute of Policy Making, a decentralized entity that brings support to Mexico, Colombia, Peru, and Bolivia. Nowadays, is a post and pre-undergraduation faculty in the plurinational state of Bolivia and a volunteer for different communities. So please, Jorge Luis Medrano. Thank you, Doctor, for the kind presentation. Warm regard to Andrea, for those who join us today, Miguel and Celi, and of course, welcome to everyone that are joining us in this webinar. We hope that will be useful for all of you, and we can fight against this discrimination and stigma of this pandemic of HIV. So without any further ado, I will share the results of this study, and of course, to thank the University of El Alto to use their facilities to share this webinar with you. So, let me know if you can see my screen. So, what we're going to see now are the results of the Index 2.0 studies that were conducted in the different countries of the region. We're going to see the countries of the Andean region, as Andrea said, Bolivia, Colombia, Ecuador, and Peru, that were included by different instances, and highlighting that this study is very relevant because it was organized and analyzed by the different representatives of the civil society of different countries. I will start with a brief theoretical framework, let you know that the context of the HIV response, the difference sometimes is not implying only the fact that a person is living or not with HIV, but also other elements are included in the humanitarian component, gender, skin color, sexual preferences, and other elements that will be considered a vulnerability issue, or inmates, or migration status. As Andrea mentioned, these are factors that are adding up as different layers, generating the stigmatization, the intersectional stigmatization. And this is a complex issue because we're not only fighting against the HIV stigmatization, that even though we have discussing it for some time, it's a complex thematic, and we also need to struggle against these topics that are increasing the vulnerability of our populations and those people that has the diagnosis of HIV. So this study tried to collect those elements and tries to guide some actions to assess this intersectionality, because this intersectionality should give us join different identities that will influence the access to rights and opportunities, both in the area of prevention, diagnosis, and the treatment with a HIV diagnosis individual. So, based on the IWARD, the discrimination in the intersectional discrimination is unique and distinct form of discrimination that is separated and results of the combination of different factors, motives that demands to work the HIV topic, and also the other layers, those people that has a diagnosis of HIV. So this slide allow us to see that those attitudes and behaviors, these are going to be translated in the terms of judgment, and is showing something, some things regarding the people with HIV, and make that these close or far surroundings try to start finding culpability, guilt, or be forbidden behaviors that make that our way to see HIV is still stigmatized. So this make that the stigma turn into a negative way of influencing power. So this is manifest with a permeabilization of the society involving different moral, ethic, and political issues, and is translated in behaviors, practices, and of course, that might affect for those who live with HIV and those who have in a vulnerable situation. And of course, we all are vulnerable. HIV is not discriminating, and as we can see, those practices and behaviors are translating in not using the utensils that other family members, people that live with HIV, are segregated and discriminated in health centers. So they are not treated in not HIV specialized health centers, are not admitted to schools or educational institutes. That's why people with HIV are not able to finish their school and they like receive provision for some employments and other types of discriminations are manifested for those people that carry with this burden. And HIV becomes a way of life. Unfortunately, people that start to look for guilt or and why do this stigmatization situation comes up ended up with situation where people is not able to continue with their life. They lose motivation to take care of their health, and they generate a layer of external stigma of self-stigmatization, and that will affect people and their surroundings. So there's no a single definition of a stigma, and we can define them as a group of attitudes and beliefs that are unfavorable, that they discredit or reject the person that is considered different, and they have important consequences on the way in which individuals perceive themselves. So the process devaluates our role as people, as individuals. So these elements are translated into the community situation, the family environment, the couple, the work environment, the health services provision, the stigmatization in schools, the stigmatization in justice, the institutional stigmatization that so it's quite complex. This issue, we have a lot of stigma in the educational domain and in different institutions that are not only health entities, but also could be translated into a fact that the person unfortunately suffers from low self-esteem and other ways of stigmatization that you can find, and we will not be able to name them all, and they are translated into a way of living. So the stigma, unfortunately, is transversal in every aspect of society, and having a HIV diagnosis is busting these discrimination and stigmatization uh, patterns. And of course, it's going to be very difficult to comply with these goals of eliminating HIV, stigmatization, and try to reduce the mortality, reducing something that is as simple as the mother-child transmission. We have so many gaps and barriers that persist and make difficult to educate our communities in HIV prevention. So this study, these index studies allow us to evaluate these questions and to improve these practices of stigmatization in HIV, especially in the Andean region. We know that we're talking about a lot of countries. We are focusing our attention in the four countries that are participating in this sub-Andean region. And of course, in all the Caribbean and Latin America, we have inequalities that are quite generalized. And in this area, in particular, we have countries that will present more inequalities than other regions with similar development structures. And of course, this limit the access of health services and HIV and key stakeholders, the diffusion of prevention strategies, information, ended up with a difficult coping with HIV diagnosis. So these institutional barriers will boost the inequalities, and we keep with this vicious circle that expand the gaps and limitations to a patient to access the quality services for health and education. The evidence is, of course, important. That's why we are working with these index studies. We know that we have discrimination and stigma, but it will be nice to know about these some statistics that will help us to make some decisions. Numbers will help, and this is what the index provide. And of course, the index 2.0 has the aim of enhance the understanding, the scope of this stigma discrimination and operates in people that have the HIV diagnosis. And of course, to understand if there are relevant differences in our countries, and we are a very similar context, and we can elaborate as well multi-country strategies in that somehow the evidence that we might generate can be used in a local, national, or international level.
El estigma, perdón, y favorecer los derechos de las personas que viven con VIH. Entonces, este estudio es un estudio predominantemente cuantitativo, está cargado de números, es un estudio que se ha trabajado con una encuesta sociodemográfica que tiene varios elementos, pero...
So we have this socio-demographic survey. We have also a qualitative aspect. We are not going to be able to listen to this. And the sampling was by convenience. And trying to find an equilibrium between the key population and the general population. So we have this sampling by interviews and sampling by place and site. We try to find for a convenient sample. As you can see, we reach 927 people in Colombia, 751 in Ecuador, 812 in Peru, and 912 in Bolivia. In Ecuador, in Bolivia, we apply the guidelines and the standardized model of the index guideline. In Colombia, also participated in the study, something ad hoc to the specialty. And of course, the results are quite similar, are not identical because the variables are different, but allow us to have some variations. The study population are 18 years of older, having a diagnosis at least of a year, to have some information on how the stigma works in this population. And if so, here we have the population distribution. And we're looking for people that simple risks. 9 of every 10 people from these countries are younger than 25. 84%, 90% of the population is 25 years or older. The sex distribution is higher in men, and in the gender identity, we find that 6 of every 10 are men, 3 of every 10 are assuming the feminine gender, and only 7 are considered transgender. From the people that we interviewed, more than half of them have an intimate couple, a stable couple during the period of the study, and from them, 20% are people that have HIV. A smaller proportion is not aware of the serological condition, and some of these people will not have a diagnosis. So how much time from the diagnosis? We try to look for diagnosis that is less than a year, and the vast majority of people that were interviewed have a recent diagnosis, at least from the last 5 years.
Un poquito las variables, la mitad, en este caso de las personas en Colombia, por ejemplo, y en otros casos, más o menos el 30% o 25%, pertenecen a la población de hombres que tienen sexo con hombres o población gay.
So in terms of the population that has men that has sex with men,
este caso son los hombres cisgénero que no tienen una orientación sexual.
and cisgender men that have not a gender orientation,
También están las mujeres cisgénero por ahí, ¿no?
and
Claro,
women
la distribución sí es un poquito diferente en cada
that
país,
are considered lesbian. The distribution is quite different between the countries that we assess. These cues will help us to find some elements that are related with the stigmatization and discrimination aspects. That is one of the relevant elements that has this study. We're not going to only find a difference by country, but we also might find difference by type of population. So this graphic show us the 2.0 difference, and we can see now that the main issue that is connected with people that have this HIV diagnosis is the internal stigma, and is a consequence of the different ways of discrimination, being an HIV positive or by other factors. We know that the external stigma situations that are related with the environment affects one or every two person. We also have the vulneration of human rights during the last 12 months. And another factor that is mentioned in this study affect also one of every two individuals, and we have some consequences of the consequences of the manifestation of the stigma and the vulnerability of the human rights. So we're going to see some results. This is the first graphic that allow us to know the proportion of people with some type of stigmatization or discrimination. We can see that this question could be considered for the first countries. We might identify that more than half of people that have HIV suffer some experience of stigmatization, showing a higher proportion in Bolivia. This graph is showing what is the more frequent ways to show the stigmatization. We see that 3 of every 10
por comentarios, murmuraciones de
were
otras personas externas,
discriminated or were
que han sido
harassed by other individuals due to their gender identity, and they were victims of discrimination comments. We have also verbal aggression and effects of the source of income, exclusion, family activity, and district are the manifestations that are moving on to the along this individual's life. And we see that from the comments, the most frequent component are this type of discrimination. And here we have some characteristics that we selected. If we, for instance, compare the gender issue, we might say that there's a higher proportion of external stigmatization in women in comparison with men, 61 versus 57%. If we 47%, and if we see the gender identity, we see that there's a good amount of people with that they consider themselves transgender. And regarding the diagnostic time, it's evident that the life history will increase the perception of discrimination and stigma for those who has more years been diagnosed. There's people that have more than 20 years of being diagnosed. So this is another characteristic. We have these populational groups by transgender, gay or lesbian, bisexual. We need to see that this is not a statistical representation. We see that 82% were women who has sex with women, but the number of women was quite small. And we also find transgender individuals, 65% of them, sex workers, 63%, that I repeat, give us an idea of the need of intersectionality, having HIV, but also having an identity or a job or sexual practices that might influence the discrimination and stigmatization. The lower table include other elements, not necessarily orientated to key populations by their sexual orientation, but other elements, and that give us some interesting information. We have to take into account some of these elements. We see that the inmates, for instance, even though we don't have too many people that we found, that we have a lot of burden of stigmatization. 65% of the individuals that have HIV and are inmates, they suffer from these stigmatization practices. We also find this practice in individuals with physical limitations, and of course, in the religious groups, 3 of every 5 has suffered some type of discrimination or stigmatization, but somehow this can be associated with the belonging of a particular populational group as an intersectionality hint. And if we analyze the data in Colombia, we're taking the same indicator for the 12 to 24 months experience, and we find that between Colombia and Ecuador, 3 on every 10 individuals with HIV suffers some type of discrimination or stigmatization. In Bolivia, we have a high proportion, almost 48%, and a little below is Peru with 22%. Here we have the internal stigma. So we take 3 elements enable to establish the internal stigma. And of course, what we see the most are feelings and emotions for those people that suffer from HIV. And how people perceive their diagnosis. And at least 9 on every 10 people, in this case, Ecuador, Peru, and Bolivia, have feelings and negative emotions. What are those? To feel appreciated, to think about suicide, feeling quite vulnerable, that are not wanting to have a sexual relation or a couple. And some of them will not wanted to belong in any social group. And they feel some negative experience. So being an HIV positive patient has some connection with sport activities or family activities, reduces those burdens. And we find in those 3 cases very high percentages. In Bolivia, have a very high proportion, and emotions or feelings is almost appearing with other 2 countries. In Peru, we see a lower proportion of almost 26% this self-exclusion.
Medir el estigma interno, se ha quitado el tema de los sentimientos y emociones.
We are assessing only negative self-perception and auto in self-exclusion. Why do we remove feelings and emotions? Because these percentages are very high. So to consider the negative feelings and self-exclusion that is related to the diagnosis of HIV, we saw that in the 4 countries, more than 60% of the individuals manifest some internal stigma situation. The lower proportions are found in Ecuador and Peru. Bolivia have a high proportion, and Colombia is like in the later graphic. In terms of the health services, We have these index studies, and of course, we talk about the educational labor and emphasizing the access of health services or situations that are related with the stigmatization in health services. And we find that Bolivia and Colombia, more than half have suffered or has feel affected by one of these health services, being comments, excess of care, doing some activities, feeling forced to have a new test, even though that they receive a diagnosis or comments or exposing their serological state without their consent. And this happens both in the health services of HIV, but also in the non-HIV services. So in Ecuador and Peru, we find proportions that are similar to 45 to 40%.
Lo que es el servicio de salud de VIH y lo que son los servicios que no son de VIH. Bueno, por ejemplo, acá en Bolivia tenemos los CDVIPs, que son los Centros de Vigilancia, Información y Referencia, que son centros de salud de VIH. En Ecuador están las unidades de atención integral también, por ejemplo, que son servicios...
And we have the integral attention.
Entonces, en esos servicios de atención exclusiva, digamos, de
So in those services of HIV services, we see that there are sensitization, that we have a lot of work in the approach of HIV. 35% of people manifest that they have suffered some stigmatization in the health services. In this case, the bigger proportion is in Bolivia with 40% compared with 30% of Ecuador and Peru.
El porcentaje de estigmatización y discriminación es más bajo que en los servicios de VIH. Ese es un punto que hay que tomarlo en cuenta, más allá de los números.
And something to take into account is that the stigmatization in health services is higher. You might expect that you have those HIV services when the people is sensitized and more trained. We find these numbers that even though the difference is quite modest, people manifest a higher level of stigmatization. It might be because some people are coming to the HIV services and the access to services that are not HIV is lower, but this is a topic that we have to take into account. In this arena, the proportions are quite similar, around 30% in the four countries. This gives us a topic of discrimination in the health services that we see in the previous graphic. In terms of the vulneration of rights, this is something that was a little difficult to work with this question because this has some story of the entire life, the last 12 months, when we have some filters that we included in the survey that we try to standardize in order to have a proper standard. So in terms of vulnerability of rights, the sharing of the diagnosis due to the or being affected with one work or the educational component, and all these elements put together, we find that, exception of Peru, as you can see, more than 15% of people that live with HIV were suffer an affectation of the rights during the last 12 months. And this is, of course, in Ecuador have higher percentages, and Colombia has 18% and Peru 5%. So one thing that we don't have here, but it's important to mention, is that there are a good proportion of people, more or less 30%, if we put together four countries, are not aware of their rights. So if you don't know your rights, you don't know if your rights were affected or not. So this piece of information might be biased because it's likely that 70% of people suffer a discrimination or affectation of their rights, and being unaware of their rights, they will not be informed, or they will not perceive if they were discriminated or not. This is something that we have to take into account because we have to conduct ourselves as peers to have access to our rights. This little table show the generalized stigma to different populations. And what we did here is to cross these minorities, these populational groups are not so key stakeholders in comparison with the key stakeholders, and we see some percentages, and we cross the Cs, the racial minority will have, in the vast majority of cases, higher proportion with the non-cis or the. So you can see here, people transgender individuals being transgender and being a minority entity or ethnic minority will have a bigger discrimination, and not being transgender and not being part of a minority will give a 37%. We're not going to see the entire table, but if we analyze the numbers, there are some factors that will increase the layers of stigmatization and discrimination. Being part of a minority will increase the vulnerability of the discrimination. So we see here some people that are inmates, transgender, will suffer also higher discrimination rates. And if we see this part of the table, we see that we have a higher vulnerability to certain groups, sexual workers, for example, transgender.
Que tienen sexo con mujeres también son porcentajes altos, pero
in the case of women that have sex with women, we also have a high rate, and we have to take these numbers with care because this is a very small sample, and the numbers are representative, and those percentages are, and we can have the statistical difference to know that, or to say that we have a layer that have an intersectional layer on those groups that belong to these minorities. And if we cross this information, the transgender and the sexual worker domain, maybe we might increase the percentages of the yes, no, being transgender or part of a group or a minority will increase the situations that are related with stigmatization. And here we have the same but an internal domain. So the individual feel self-excluded, they have negative feelings, they feel more vulnerable because of belonging to a particular group or a populational minority. So here we have the yes people that are considered people with HIV, transgender, and being a minority, a racial or religious minority. This little group showed that 92% of individuals have that internal stigma against 32% of people that are not transgender nor belonging to a ethnic minority.
otro casito también.
So here we have another interesting case that has to be taken into consideration. Being transgender and being part of an indigenous community and having HIV made that 100% of these people feel this stigma in an internalized manner. So if we analyze this number, we see that the vulnerability rates are higher in sexual workers and women that have sex with women. This is a summary that allows us to see the stigma and discrimination, but by key populations. So this allows us to do like a hue, analyze the hue of levels of which groups of population that have HIV manifest higher levels of stigmatization and discrimination. And here we can see that the higher proportions are in the transgender groups. In this case, Peru has a higher rate of Bolivia, and in Bolivia and all the domains have a high proportion. And here we have Peru in the case of gay or people or men who have sex with men. We have the high rate in Bolivia in 62%. And here we have the rates of Bolivia and Ecuador. Here we have 45%, the percentage of stigmatization and discrimination, 55% in the case of bisexuals, 40% of sexual workers, but we have also different hues. In this case, Peru has a proportion higher than 50%, and drug users that are not that much. It's not a huge sample, but we also find a higher proportion of this discrimination hue. So it's important to mention that many drug users are not the injectable, but any type of drug that we're taking as a reference, that we're taking as a vulnerability condition. About those numbers, I hope that I don't tire you with the numbers, but we have some intersectional strategies. Here we have some lines, and we see that it's needed to keep strengthening the educational domain in HIV. We have many people that do not know what are their rights. Many people are not operating in their right domain with active participation in HIV people with the decision making. So to and not only the discrimination domain, but all other areas. So if you help me, I would like to end up the fight against HIV. And our goal is always love and understanding. We know that many things are connected with the family. Every individual deserves respect. So this discrimination stigma perpetuates the taking care and the treatment of these individuals. So as Andrea mentioned, and Dr. Carmen, we have to work together. It's not a recent message, actually comes from some time now, and we need to be changing agents. These are the instances in which we can behave or we can intervene to look for spaces to make some changes. Otherwise, we're not going to be able to have some results. And we had the duty of fighting not only with HIV, with other types of discrimination. We need to break the stigma. Let's keep living without discrimination. So it's important to promote equality, but of course, equity. And with that, I finish this intervention. Sorry if I extended my time. So I am available if you have any question from the audience. I am happy to be part of this meeting. Thank you, Jorge Luis. Quite interesting domain. It's filled with a lot of questions. And of course, some comments are coming, and we invite you to keep in the room. And of course, we're going to keep the dialogue based on the questions. But with this lecture, it's clear that there's a message that comes from some years. So the HIV is not discriminating. We are the ones who discriminate. This is a limitation that we see that in the concept of health and the having quality of life, discrimination, unfortunately, is limiting this right. So we have seen with a lot of concern that table that you show with the internal eczema, the self-exclusion, but they do not come by their own. This is not proper from people, but it's a product of the environment and all the factors that might condition it, that the individual might feel excluded. So it's quite sad to see that not only the HIV services, you might feel that this stigma is there, but also in the other services. So we have a lot to do in that domain. It's true that that study, as you mentioned, is addressed to some individuals or women or children are not always subjects to be considered in the statistics. And of course, we can request hundreds of analyses. And I think that almost 4 years ago, we are repeating the same thing that we need to confront the stigma and discrimination. And we wanted to find evidence. And of course, the evidence is already there. And as Dr. Cayo said, we cannot be just passive witnesses. And as we did this study with participation of empowered community, so I think that we need to keep working with these communities as allies to monitor this and make it easier to have this articulation with the ministries and promoting concrete actions, and we can eliminate stigma and discrimination. So it's clear who are those who are the most affected. But as I mentioned before, sometimes this hides some internal uh, gaps. These are extremely useful information, as Dr. Kai mentioned. The communities are discussing, so the most we discuss about it, so this is going to accelerate the response. So just to continue with the challenges and the Latin American network of HIV patient, I would like to welcome Margelina Vera. Margelina is a sociologist with a gender approach, and a feminist with a lot of experience with planning and implementation and coordination of projects with a gender perspective. In her vast experience, she centered her efforts to strengthen, especially HIV positive women and migrants in areas that will strengthen something that is so important, the economical autonomy and reproductive health. He has more than 10 years of experience in reproductive health in Colombia that were financed by different international entities that provide the experience and the development of analysis and context, implementation of projects and strategic alliances with important entities in different sectors, addressed to the sustainability of these intervention processes. She always mentioned her commitment to contribute from their experience to promote the autonomy of women, aiming to reduce the vulnerabilities, the structural vulnerabilities that will guide some of these conditions. Currently, she is in charge of the HIV and gender in the Health Network of Latin America and the Caribbean. Thank you, Marina, and good morning. Good morning, everyone. It's a pleasure to be here in this space, being able to share with you the reflection that we have from the LAC network related to discrimination and stigma, but this in this opportunity, how this is affecting the body of women. I would like to start with something that was mentioned during this session, that was mentioned by Dr. Medrano, and is the internalized stigma, both in the study that was made by a lab and the study that we have in Colombia, talks about this stigma in different manners, and is how, for the case of the study that we have in the region, this is understood as a group of ideas and beliefs that sometimes are seen that when I live with HIV, I am less worthy or I feel dirty, and they go together with some negative emotions such as fear, embarrassment, and all of them are related to the HIV, living with HIV. And in case with the study that we developed in Colombia, this particularly consider from the transgender and cisgender women, talks about the reduction to access of individuals HIV to the health services. So we here also feel the fear of of cisgender women and transgender women, they feel this loss of a social status in the environment that they live with. I would like to center this talk in this slide, sharing with you a reflection that was established from women, because we talk about this poly-victimization, because basically, as you might know, the internal stigma is almost the the main responsible of those trends that people with HIV have this internal stigma, how these people is affected by the external stigma with less intensivity, but quite strong either, and the topic of exclusion and how do I feel myself to be treated. And we see how this is. I see that in the comments that someone talked about this campaign of indetectable and intransmissible that has a lot of strength, because we prefer not to talk about this issue, would not expose ourselves, because we prefer somehow to give all this burden to the internal stigma and not being exposed to all of these things. So that's why we talk about poly-victimization, but also associated to women. That is part of the task that from the network I was responsible of, and I wanted to bring some elements connected with this concept about a regional study that was conducted from violence and women with HIV in Latin America that was part of the network. And in this, we talk about this public victimization, and it's a little different from this side in how violence and the economical burden, any type of violence, make these women, we have this poly-victimization, suffer from a bigger stigma, or will strengthen the internal stigma, and that will connect ourselves with the violence that we suffer from the gender that we used to suffer due to the mere condition of living with HIV. Some women express themselves that they have this health condition, one way or the other, put them in risk of being vulnerable just for being partners, or due to the fact that their couples do not want to be with them, and women have to assume different types or receive different violence, to live violence just for that condition, because we used to think that women, it's part of the internal stigma that we are experiencing, that I don't have the right of living my plenitude even though I live with HIV. And of course, this is putting me in a bigger victimization. And the reflection that I wanted to leave here is, how do we connect with this issue of having a stigma or discrimination, but also being women in an environment that will be the poly-victimization that, of course, is gathered in the study that we do from Alec, but also something that brings to this study. This is where majority we evidence that multiple violence will have an entire connection with HIV that increases due to the condition of living with HIV. I would like to share with you this exercise also, and how Dr. Medrano mentioned it in terms of how this stigma discrimination entity is related to the reproductive and sexual health that manifests women. The fact that we have lack of access of sexual health or reproductive health in a conditioned manner. We do not enjoy our sexual rights or reproductive rights, just to the fact that some people feel pressure to feel to to find a method to feed babies, because because this is part of the
está sucediendo con las personas
it's part of what is happening on with people or women currently that wanted to breastfeed their babies, and we don't have scientific evidence that show that the breastfeeding might generate issues, and so there's a huge pressure, and of course it goes against the reproductive and sexual rights. We have a manifested pressure on this study because we have 7% of pressure, 7% of women that were interviewed. They felt that they have some difficulties to take antiretrovirals during the pregnancy. And of course, we all might think that the quality of life and adherence is extremely related. And this is something that is a pressure that conditioned them, because this is something that exercising some power in top of their decision. This is not a consensuated decision. It's not a space where women will have more information and they feel it as a pressure. So regarding why we have this pressure to decide on a specific method, for example, to decide how to deliver your child, the anticonception or the anticonceptives is also a matter of pressure. And even though that we consider that as normal, because of course I have to take my antiretroviral therapy to reduce the risk of the baby, clearly the exercise that is important to understand here is that we have an action, or we have an exercise of power that is executed in that dialogue between those who are assisting us in the reproductive services and women that live with HIV. So it's evident, or they feel it from women, that they have a stronger symmetry for those women that might feel with less information but quite pressure. So it's not a free exercise that allow them to take this decision freely. Next, please. So Dr. Medrano also mentioned it. This is basically something that connect one thing with the other, and the studies are only showing that the structural factors, you might think that the stigma and discrimination will have nothing to do with this structural issue related with the cultural issue, with the perception of the epidemic and the different ways of transmission of the disease. So part of what we analyze on a structural factor that has to be taken into account, and Dr. Marianela mentioned a little bit about them and how important is the incidence. I think that we also mentioned that basically we have some movements and commitment with the red flag, and how can we generate concrete actions of incidents and political advocacy, and how these structural factors are not only analyzing this issue from the health sector by the appearance of the epidemic, but also considering it from the social context, and to recognize the structural vulnerability, especially for women, that is associated with their condition of being women. So in the frame of the recommendations, we have the education. This is something that is considered generating educational opportunities in part of the empowerment of women, thinking about education. And I would like to share with you that something that I analyzing the results in Colombia. It was read that the study shows that this exercise of the stigma and discrimination, beyond being a social phenomenon, a highly complex phenomenon, of course, is also affected with this intersectionality with other conditions, such as the sexual orientation, gender, and the population that is a victim of the conflict or an armed conflict. And also is showing that reducing the possibility of discrimination associated to HIV is also quite related to the increase on the school attendance, especially in women. And if you see what the studies have shown in the process that we see not only in the regional but also in the national data, is that women, just for being women, have some structural gaps, structural barriers, but all women have access to formal education, and that make that do not many women do not have access to formal education, and that's why we have less possibilities of accessing a social position and guaranteeing our social rights and also pension rights. So that's why it's so important to generate the spaces to promote autonomy, and of course, this will have to be related with something that is quite orientated to self-sustainability of the exercises that might include how to strengthen women in the framework of entrepreneurship, but the entire infrastructure that will guarantee this. In the area of health, it's important to mention that it's important to implement actions for prevention. I insist in this domain because the combined prevention talks about how can we change these behavioral structures. For instance, today we cannot think about generating actions in the frame of prevention, at least that have a gender approach in the same way. We cannot untangle the vulnerability of women. We cannot disconnect the violence issue and the gender violence and the same inequalities of an action of prevention. We need to put it in the same domain. And that's why, starting from the prevention actions, we need to include this exercise that is addressed to women, but of course, recognizing these vulnerabilities that is part of the inequalities of gender and also the needs that are generated in the health and reproductive agenda. And we see that the only single country in Latin America that was able to give responses to the prevention or to the female condom is Chile. And of course, we are witnessing that in other Latin American countries, we don't have them because it has been understood that this is a very expensive product. And of course, we need to insist there that we need to find that connection related on how or what is the need of women in reproductive and sexual health. And of course, that is related to the reduction of the stigma and associated discrimination of living with HIV. And one of the last one is to prioritize
y viéndolo con ojos o con las gafas de género y con un enfoque feminista, pensamos que priorizar el desarrollo de las competencias para la inclusión laboral
from our gender approach to promote the conditions for work inclusion, something that I mentioned before. This has a lot to do with the economical autonomy that will be a factor that might help to reduce the violence based in gender. And as I mentioned before in the study that the ECW established, I will share with you the reflections and recommendations that came out of that study. And I wanted to share it with you because I know that this is a multiple variable study. And of course, we contemplated the most relevant of them, but to accomplish this exercise, when we talk about women, it's important to highlight that we have different needs. And that's why we need to include the differential approach and the gender difference, particularly thinking on women from a feminist perspective. So I would like to share with you a little bit about the reflections or the conclusions or recommendations that we had in the frame of the study. And the first conclusion is that it's extremely important to include all the health determinants that we see in the conclusions of the study on the recent studies of stigma and discrimination. And it's important to include those social determinants as education, work, poverty. Also including the decision, the access to resources, and especially the women with HIV. And it's extremely important to in the frame of incidents, and I connected with of the political agenda of the red flag, and we can establish policies and plans and social determinants, and to include the policy, the political view, and somehow perpetuate violence and the connection of violence with HIV, and one way or the other increase inequalities scenarios. And that's why from the red flag we are quite connected with these global strategies that are the objectives in the 2030, and particularly with the goals and we need to include establishing an important factor to consider, and these violent elements. And I wanted to let you know that it seems like when we talk about gender, we cannot say that one vulnerability puts one in top of it. So particularly happen in the reflection how we are suffering this in the HIV approach, and how we are understanding that the gender agenda is centered in the gender diversity, but also when we talk about a gender issue, I would like to invite you to look at it from a feminist approach, because this gathered these inequalities and those gaps that were generated by the condition of being women. Another recommendation that I consider relevant is the fact that it's quite connected with this issue. And I was telling you a little bit about the story of the gender-based violence and how these programs are developed, in which we connect the gender violence and women with HIV, especially with HIV, and how we associate it in this risk condition, living in a permanent violence, and I could live with another sexual condition. And we have like a connection, but this connection needs to find a programmatic response. And almost any program have it, because in particular, we have identified that the band programs
también es parte de los desafíos y es lograr la
this is part of the challenges to accomplish the intersectorality. That's why it's so difficult to think that giving response to the reduction from this structural factor, when we talk about women from the structural factors, we need to think about that there are other people involved. And it clearly needs to present political willingness, but some of the missions, networks, and organizations is to find this perspective of this condition of living with HIV, to understand how can we construct I would like to thank you the space. The next slide, and I can tell you, and especially giving a voice to women I hope that we can
Julia
gather
no quería
the majority of
ya el doctor me
information.
traía como todo su argumento desde los números, pero creo
Doctor
que
mentioned all the arguments from the numbers, but I think that where we're bringing is the experience
la
of women and
violencia
how
sobre sus
violence
cuerpos, sus vidas y ha determinado de una u otra manera, ha ampliado las brechas
have enhanced the
para
gaps
las mujeres que viven con VIH.
for
Muchas
women
gracias.
that live with HIV. Thank you so much.
Las gracias a usted, Margeline, que ha tocado temas claves, ¿no? El reconocer la
Thank you, doctor, to
vulnerabilidad
recognize the vulnerability in
de
this
ser mujer,
infrastructure
lo que
of
significa ser
women, what
mujer
it
y
means to be a
tener
woman
VIH y tener
and
familia,
having HIV, having a family,
y estar a la vista
and
desde los movimientos
also
sociales. Le
being
pidieron, lo
in the
enseñó,
scope
lo
of social
pisaba, el
determinants.
lavado de manos cuando la mayoría no tenía agua.
And we're talking about hand washing when people did not have water, or we were,
Muy lejos, cuando no hay unos horarios que nos
and we
permitan
don't have
realizar una cita.
timetables that help us to
Que aborda
get to an
precisamente
appointment
los
and
determinantes y
approach
siempre con
the
esta
social
mirada.
determinants,
Lo que estamos
but with the
haciendo,
gender identity. And I think that we're
el
convinced
empoderamiento de las
that
mujeres
the
que se ha trabajado
empowerment of women
en
connected with
Bolivia
autonomy
durante
will
tantos
help.
años que se ha trabajado en los
And there are
derechos
so many years
sexuales
that
y
we
la
work with
reproductiva,
social
esto va
rights,
ligado a capacidad de
and
decisión.
this increase our
Mujeres que
decision making.
deciden, pero deciden sobre la
People that
base de
decide,
la
but they decide in the
información,
base on
del
information,
conocimiento y
empowerment,
del consenso también
and
con toda la gente.
consensus with all
Creo
the.
que los aportes que usted ha dado son
I think that
fundamentales
your
cuando hablaban del tema de
support is
discriminación,
fundamental when we talk about
de Jorge, ¿no? Donde derechos era una parte pequeña, pero es
why
que
was
en aquellos no
rights
había
was a
mujeres,
very
derechos son
small
derechos.
domain
Eso
because
no
people do
está
not
visibilizado. Entonces, creo que
know them, so they are
esta
unable to know if they are
conversación es
vulnerable.
clave para
So it is
abordar
important to include
este
all these
tema
right
de
awareness,
violencia política.
including this incidence
Gracias nuevamente.
domain. Thank you so much.
Preguntas, Vanessa.
I'm sure that there are some questions.
Quiero
We will
darle
be
la
kept
bienvenida
in
a
the
la
room.
doctora Andrea
I would like to welcome
para
Andrea
que en
Cardi.
estos momentos ella pueda
So right now
hablarnos desde
we can
Bolivia
include
cuáles son esos retos que nos siguen. La doctora Andrea Bocardi Vidarte,
Andrea Bocardi
la Oficina
is
de
the
Desarrollo
director
de
of the office.
ahí está Perú, Ecuador, Bolivia y Colombia, ¿no? Y está ubicada pues
We have
en
Ecuador,
Lima
Bolivia, and Colombia.
desde el año 2020.
We are located in Lima from
La doctora
2020.
Andrea es médica, especialista, es
Dr.
ginecóloga,
Andrea is a
y tiene
gynecologist,
especialidad en la atención de niñas, niños y
and
adolescentes.
she
Además,
has a specialty in the
como
treatment of children and adolescents. She
del Ejército
works as
Nacional,
an
de las
officer
Fuerzas
of the
Armadas
National Army
y se encuentra en situación de reserva. Nuestros respetos,
of the
doctora.
Republic of Uruguay, and our
Cargo
deepest
de coordinar
appreciation.
los contingentes militares
She
y
was in
civiles
charge of
en las
preparing the Uruguayan
misiones
domains
de paz de las
to
Naciones
being a
Unidas
part
y
of the
ONU.
peace missions in the
Trabaja en
United
USAID desde
Nations.
hace ya 20
She
años
worked in USAID for
ha
20
tenido
years,
múltiples cargos de asesora
and she
civil a nivel
occupied
regional en Panamá
different
y
positions
nacional en
in
Ginebra.
Panama
Ha
and
sido
Geneva
seguridad y
in the areas of
responsabilidad
security,
humanitaria, planificación y programación estratégica y
planning, and
política, escrutinio de la
strategic
atención
and
y
planning,
programación estratégica,
and
entre otros.
strategic programming, and others.
La doctora es casada, tiene dos hijos, qué bonito que
She's married, she
pueda
has two children, and
expresarnos.
that's so nice to
Adelante.
include it in the presentation. Please, Dr. Boca.
Gracias, querida. Voy a tratar de ser breve para tener más
Thank you. I
espacio
will
para
try
la
to be
discusión.
brief to have some space for the
La
Q&A.
cuestión, bueno, en función de toda esta evidencia, en función del
Based on this
análisis
evidence, based on
que
this
aparte ha sido
meeting, it's important to analyze that
porque nos haya levantado esos espacios, esas brechas que ya se están
these gaps that are
entendiendo en los
clearly
números que Jorge nos presentó.
apart from
Entonces,
the numbers.
brevemente, voy a presentarles a ver qué me sales tú en la pantalla. A ver cómo, aquí, ok, disculpen. Voy a compartir pantalla.
So I will share the screen.
Sí, estoy compartiendo.
Let me know if I am sharing the screen with you.
Hasta modo presentación.
Listo. Entonces,
Okay, fantastic.
comentarles.
So I wanted to let you know that in relation to
Bueno, de alguna manera a los cómo
somehow
estos desafíos
how can
que
we deal with
conocemos
these
que están
challenges
ya
that of course we know it,
algunas personas que
we
hemos
know them
estado
right,
vinculadas
all the people that was connected and committed with the response of the different sectors from 4 years, we know what are the barriers that we are finding and what are the determinants of this generation of stigma and discrimination that is chosen in the key stakeholders. Very briefly, what I want to mention is to have a brief analysis of the findings and how these findings are in line with some specific challenges. So I would like to ask you to join me, witnessing some elements that might coincide in the 4 countries. So we have a very concrete analysis related to the situation that we suffer from the HIV individuals and all the community from the beginning of the pandemic 40 years ago, and here we are still. One of the main gaps needs to be considered also some external factors that are also in this conservative concept of the Andean countries. And this is something that we also see with the COVID-19 pandemic. So how can we affect it? How this population were affected with biggest difficulties to access to the health services. So how this conservative context will also be called by its name. And when we have groups of anti-rights and that question those progresses, social, political, normative, that take so much time to make incidents in those countries that will provide a worthwhile HIV population and diversity groups and those marginalized communities, transgender, those who are private of their. This particular context that is quite conservative that affect the social and integral comprehensive education schools that leads to avoid the gender issues and generate stereotypes that what we do is to emphasize or manifest in different manners as a specific context of violence that is addressed to women in the entire diversity as feminicides and transfeminicides that nowadays are a new epidemic, a new pandemic in a wider context, unfortunately. Of course, one element that Maya mentioned that is extremely important to take into account is the poly-victimization. The particular element, and that is when we find ourselves in this violent situation based in gender, not only for women, but also the diversity domain, and how this leads to have a manifestation of the specific elements such as physical violence, lack of security, violence, and assassination we are witnessing. We are witnessing that in the health context, even though that we have protocols of attention that could be differentiated for a specific population that might suffer from some discrimination, lesbian, bisexuals, as we see in some evaluation, those protocols are not implemented properly. Therefore, when this population require some assistance, we have this environment where, unfortunately, we do not find their response for their specific needs, and directly they are mistreated. So we need to analyze the concrete situation that some countries are experiencing, especially Peru, but also happened in Ecuador, Colombia, that is translated in emergency situation, such as the violence of sexual workers that unfortunately suffer from lack of attention, many of them living with HIV, trying to look for safe spaces that are affecting their income and also the adherence to work. And that's why the health is affected and the community health is also affected. And another examples
que queremos resaltar particularmente es que
that we are able to access the high level of 60% of all countries presented very high levels of internal stigma. And this is something that was shown of the polyvictimization. It seems that we combine in the presentation because it's an evolving cycle in front of the violence and lack of access of internal stigma that is manifest in a different manner. Violence, transgender, physical violence, economical violence, but thereafter, discrimination in the provision of services. And this becomes a very extreme internal stigma that at the end of the day limit our individuals to be exposed to these situations because they felt discriminated and then stop attending the health services. And those people that live with HIV that somehow were key populations that look for some services and feel discriminated in those health services, that means that we are losing them in the system. The concept of intersectionality, I don't want to repeat it, but as David mentioned it, and somehow we see that these women, cis or transgender women that also is an indigenous and live with HIV and somehow migrates those layers of discrimination, that intersectional discrimination is potentiated, and as we saw in many cases, it reached up to 100%. So it's a huge burden and quite concerning. So we find also the concept that we find in some places, the weak democracies, where we don't have a sustainability of the institutions that need to become responsible based on the provision of services. And of course, this makes that somehow we don't see a comprehensive look of the services. We have a proper provision of this. So remember the institutional absence when we have the further parts of when we have rural or indigenous communities. Of course, they will not have access to health services or other services. We find studies as well of perception, direct perception of human rights violations. And they do not respect the confidentiality, and we have a lot of complaints. And we reveal from the staff, but also we see it in a total misknowledge of the serological state of the individual. And Eileen mentioned the topic of when we see closer look, how are we going to approach these different levels of stigmatization and the self-awareness, the internal stigma. And from a logical framework, we have to take into account that the commitment of the countries to approach this problem. So in our proposals, we to work in the national response to make sure that we have these only actions, but also a monitoring strategy and specific indicators And we have indicators and guidelines, and these guidelines are extremely important because what we are not able to measure, then we're not going to have the chance to have a frame, a monitoring or a space, an observatory of the community. So to make sure that we have a standardized format in this opportunity, to different reasons, we were unable to do it because Colombia previously analyzed the index using a protocol, taking some indicators that could be considered from the subregional approach and compared with other guidelines. But this is an element that might hinder the subregional approach, the work that we are doing in Colombia in relation with that regard. As I mentioned before, we need to include them and demanded by the affected communities, and we need to see how can we facilitate the elements and tools so the communities of these populations could be able to take, together with the agreement,
específicas, al menos en estos 6 contextos.
specific actions in those 6 domains. As I mentioned, we don't only can depend upon the health services. There are sectors related to education, work, access to justice, the community domain when we talk about gender issues, and also humanitarian crises or emergencies such as the migration crisis. Within the instances that we are working with, we have the political commitment from ORAS ONU, and to update the sub-regional plan. In that regard, we can complement it with other Andean communities, trying to reduce the social inequalities. And that's how, from a normative component, we can access through ORASCON. So I would like to invite you to be part of this domain, not only the health staff that is joining us in these different initiatives. So I will ask you to join us in the work with the community so we can ensure that no one is left behind. Those marginalized populations suffering with HIV feel limited to the access of health or becomes victim of any type of violence. So if you have any question, I will stay here and I would like to give you an opportunity to have a Q&A. Thank you, Dr. Andrea. I think that we have a lot of work. You just mentioned that we are going to update the regional plan to contribute to the elimination of the discrimination and the stigma. I think that the components that were mentioned today and were illustrated by every single one of you establish the guidelines or establish the path that we need to follow, including the monitoring of the community, to make the topic of violence visible, the gender agenda, and to standardize our path, because people asked about information about children and to analyze the life scores approach. What do adolescents, what do women of think? And that will be important to know. So people that join us and are keeping with us know that we have a long path to continue walking. And of course, this could be an articulated pathway because together we will walk. And just to let you know that we have a lot of interventions in different stakeholders, and we need to build on top of that to systematize them and to work together and having with bigger impact. Ecuador is part of the Global Alliance. We have an action plan with 2 ministries in regard of serving different populations, implementing some actions, and now we just received the confirmation letter with the Ministry of Justice that is requesting to be part of the alliance, and now we are establishing this dialogue with the communities to put that work together. But in the framework of a national policy of human rights, that we have stakeholders that analyze the multi-sectoral approach, the topic of the discrimination issue, so we can build in top of the efforts that we already have, but we need to start by one point. 2030 is coming closer, and we need to reduce that barrier. So just to let you know that we have a lot to work with. So thank you so much to our three speakers, and of course, appreciating the participation of the committees of HIV of the three countries. We have Argentina, Belize, Bolivia, Colombia, Cuba, Ecuador, Spain, Guatemala, Nicaragua, Peru, Dominican Republic, 41, and Venezuela. I'm sorry that I don't mention you all, but we receive a lot of regards and appreciation. So to start with a brief dialogue, can we open our cameras? We have in that frame.
Patricia, ¿cómo está usted? ¿Cómo está? Bienvenida.
Hello, Patricia. How are you? We were kind of to join us.
Ya hemos hablado del plan, de la
So what will be the starting point? We know that we have many work to do. Where do we start with? We talk about the intersectionality, strategies, and you have any comments to share with us?
¿Está usted, Jorge? También hay otra pregunta sobre.
So we have a question. Can we say that there's a lack of visibility of women and children that live with HIV in the network?
Bueno, yo quisiera, Patricia, ¿quieres intervenir y luego te doy la
Patricia would like to do it.
Adelante, adelante. Yo puedo después.
Okay, bueno,
Okay,
yo creo que
so I think that for us, it was a great effort from the local entities and to strengthen women. And we clearly, the epidemic, the numbers in some countries in relation to women are always smaller, but indicates that the spaces are smaller as well. And we are now in a patriarchal and a male chauvinist culture. Not every woman is ready to participate, and we feel that we don't have enough possibilities for us. I think that we don't have so many scenarios of participation. We need to work a lot, and part of the challenges that we have in Red Lake in the regional level is being able to strengthen the women to generate the competencies so we can earn those spaces, because clearly we have to, we need to be in those spaces, but also in the scenarios of participation, and clearly we need to recognize what are the effects of women. So I think that the spaces for young ones will have a different dynamic and not necessarily are included in those spaces. From Alep, for instance, it was a big challenge to connect the young ones to the different scenarios, because we need to understand that they live the epidemic in a different manner. So this is my perception. Thank you. What innovative strategy are important to sensitize the population about this topic? Especially, how can we promote the sustainability of our proposed actions? These are key issues.
Involucramiento y sostenibilidad. Doctora Andrea.
Gracias. Mira, comentarles que
Well, let you know that in
que
the
recibe por parte de la Alianza Global, la alianza viene
so the Global Alliance is coming with a package of interventions, successful intervention, the six sectors based on evidence, and we are requesting it to be translated to Spanish, but it was launched. The second guide was launched last week, and the system of monitoring that was proposed is a package that comes with the proposal. So there are many initiatives, so we need to take into account that we always work from the beginning with that image of the shadows.
La información, una información que esté basada
And of course, we need to base our approach in evidence-based strategies,
en ese proceso,
knowing that the communities has to be involved in those processes. And of course, some of them are doing naturally, but sometimes it requires a little more support. Just to give you a for instance, there are many approaches. In one example of it, in Peru, where we have a specific situation where we don't have access to the comprehensive health status for HIV and tuberculosis due to the migratory nature of them. With the International Association of Migration, we were able to train some activists, some young activists, where we were able that using social media, and this is the way that we communicate with each other with the population, we issue some information in a very clear manner to the peers, to our language, to show and demystify some myths in regard to the transmission of
desde un marco incluso de
the frame of inequalities, in the frame of justice, because we're talking about violation of the human rights. So there are many approaches with specific populations, with reference that be able to talk. For example, the monkey fever, it was a community work, was fantastic in terms of communication, information, education to the population, so we can make them understand how the resources has to be invested properly. Afterwards, one of the main elements of Jorge was the lack of knowledge of their own rights. We need for those populations to know their rights so we can demand them. If you don't know that you have those rights, you are not going to feel that we have those gaps.
La sostenibilidad
And of course, they are not going to move. So the sustainability is determined with a community participation. The state has the obligation of provide this type of free services, but the ones that we're going to send the information and will be being responsible of the accountability will be the community members. So that's how we will have everyone responsible in the health sector. So
de cómo participan en todos estos esfuerzos. Quedo por acá, hay muchas más.
Adelante, Jorge.
And that's my opinion on the topic.
Un cachito se me fue el internet, mil disculpas.
Thank you.
Tema que creo que es un tanto todavía complejo el abordaje.
Something that it's still complex. We are in a scenario of new challenges. I think that you have this digital gap, trying to deal with fourth generation in the work environment, trying to standardize the way when we communicate, and it's important to think how we deal with these new approaches from new authorities, from new leaders. And I think that it's different to to communicate with a millennial, a young one, or the centennials that are not getting into the work environment in this generation that is emerging. And of course, the system or the language is not the same. But anyhow, independently from our age, we are still witnessing the stigmatization, maybe a little unupdated. So from the community initiatives, it's important to create those new leaderships. And I think that with something different, I think that the new way young ones communicate is different. So we need to adapt our language, the way they see the world, the way they perceive the world is extremely different.
Y también los profesionales, pues, que están ahora
And also professionals that are
son jóvenes millennials, como digo, no médicos millennials, que seguramente tienen otras también características y creo que ahí es necesario.
And of course, it's important to share with some characteristics to work with this situation because we can have some strategies that we designed for the last 40 years. And of course, we need to deal with these challenges. And I think that it's extremely important to start with the young ones. It's a very complex topic because HIV and sexuality is so controversial to work with parents, and it becomes a stigma or a taboo to talk about sex. So
cambiar la situación cuando ya los jóvenes
it will be very difficult to change the situation once they are 18 or 20 years, and some of them already are already infected with HIV. So I think that we have to set the starting point or reestablish the starting point, trying to reduce the risk of this population. Now the digital change, the digital adaptation is so strong that you don't even find out that how the things work, and now we have a new stuff going on. So I think that that's another challenge, and I see it also as a barrier that we are not speaking the same language with different generations. And if we don't speak the same language, it will be very, very difficult to understand with each other. And of course, generate new allies and the huge burden with the health authorities when the HIV issue is not only a health condition, it's an intersectional relation with other areas of other sectors. So that's what I will suggest. So before I give the word to Angeline, there was a question related to the from the audience, because we talk about the stigma in the health entities, and we know the reasons why these numbers, what the human resource will need, training, fear, lack of pre-exposure therapy, the distance between the population and the health entities.
Bueno,
Perdón.
no, sigue.
Adelante, Mayer.
No, es que mi aporte iba en relación un poco a pensarse en un
Well, I would like to mention that
a esta carga tan fuerte
the
que hay de
challenges, and I come back to the burden
que
of the internal stigma,
sobre cómo
and I
fortalecemos
think that it's a
las
great challenge on how to strengthen these components, because one of the aspects that we see
cada vez hay menos
in the
grupos
studies is that every time we have
les gusta venir.
lesser and lesser support
¿Por qué
groups,
se
because
demora
people
eso?
don't want to
No
come to
hablar
the
de la
support groups
enfermedad,
because they feel
no hablar de lo que significa vivir.
that
Y creo que ese es el mayor desafío. Siento que los
they
jóvenes
sometimes do not
pueden
know
avanzar
how
porque
they live with
saben
HIV, and the young ones are
Medrano, digamos,
moving
hay
forward
modelos
because they adapt.
hay
As Dr.
modelos
Medrano mentioned, there are new
científicos y algunos lo asumen,
challenges in
asuman
technological terms.
las
Some of
redes y
them
demás para hacer
assume them, and
incidencia
now
y
the
en fin,
net,
dar
the social
análisis.
media to
Y
do
realmente el desafío
incidents.
en el caso de las
Today,
mujeres,
the great challenge
sobre todo en los grupos etarios que están más
for
cerca
women,
de
especially the sector
los
groups
30 y de ahí para arribita,
such as the 30 or
poder,
to older,
digamos,
it's quite difficult to find new leadership, to put the face of visible exercise. And it's sometimes related to this exercise of trying to strengthen and
ver cómo también se genera un cambio en el discurso
see how we can make a turn on how you can show this discrimination technique to generate new proposals or exercises to go together and involve in people that will start with this new diagnosis that were unable to socialize and to generate this health affection. Thank you so much. I don't know if there's any other comment.
Si me permites, sobre el tema del personal de salud y qué es lo que esté faltando o qué. A ver, yo soy personal de salud y me identifico. O sea, en la carrera
And I
universitaria.
identify myself as a health staff, and during the undergraduation years, you are not trained to be tolerant or to be inclusive, and people that do not have that direct contact or do not have the information by prejudgment or different ways of how the instructor, how we structure a stereotype, it takes to the health staff also. In meantime, we wait for sensibilization. We have some bias or some disbeliefs or wrong beliefs. We need to do a sensibilization work because knowledge and sensibilization that we need to do to work in hand with hand, and also to identify and which conditions we can offer the services, because there are multiple ways of discrimination. I'm sure that you are victims of other discrimination arena. So it's quite complex, and I would like to share with you that every single country have developed some tools. And in case of Bolivia, we have what we call the pulsometer against discrimination and stigma. And it's a very interesting analysis of every single one of the health staff before the sensibilization and then the process of sensibilization, to see what will be the bias or difficulties or how we confront these issues. So there's a lot of tools that we were able to generate that are quite interesting in the region, and we hope that from this work we can, with Horas ONU, we can bring all these tools together so we can share them in the network. Thank you so much for the audience, and if we don't able to answer them, I'm sure that we are going to take into account for future technical meetings and sessions. Thank you so much for your attention, and until next time.
Cerrar este espacio y también el agradecimiento a todo el equipo, ¿no? Si usted ve, aquí está Yadira, que está viendo todo el tema de recursos.
Here is Yanira, the whole time. Milagros.
Está Rob Espejo, está Rubí, que canaliza, es todo un equipo. Entonces, muchas gracias a todos ustedes.
Thank you so much, everyone. We wanted to send our appreciation to Medrano and Dr. Andrea Bocaldi and all the participants. Thank you so much.
Y antes de terminar, yo les pediría solo en un minuto un mensaje final. Y aquí sí me voy a permitir, por favor, cederle primero a Giseli, ¿ya? Que está ahí en la plataforma, un mensaje final, y luego Margeline, que también sé que va a ir a otra reunión muy importante, a Jorge, y finalmente a la doctora Andrea. Adelante, Giseli.
Muchas gracias, Marianela. Y bueno, primero felicitar los esfuerzos que se están desarrollando, ¿no? Más allá de esta presentación que es excelente, yo no tengo palabras muchas porque todo se ha dicho desde las diferentes intervenciones que hemos tenido, nada más mirar, nos corresponde y estamos muy preocupados y preocupadas por el tema de los esfuerzos, de los desafíos y retos que tenemos para implementar este plan de estigma y discriminación, de eliminar el estigma y la discriminación en la región, ¿no? Ya se han mencionado el tema de los grupos conservadores, de algunas cuestiones que estamos ahí. Son 40 años de epidemia en América Latina y todos los esfuerzos no nos han permitido en algunos países como los del área andina, por ejemplo, ni siquiera erradicar la transmisión materno-infantil. Entonces, tenemos muchos desafíos para la región en torno al estigma y discriminación. Necesitamos eliminar leyes que criminalizan a las personas con VIH, incluyendo las gestantes, ¿no? Hacer un ejercicio de ciudadanía, hablar con transparencia hacia la sociedad qué significa tener VIH, descriminalizar, desestigmatizar. No es una tarea fácil, hay que trabajar con un lenguaje incluyente. La sociedad tiene que conocer. Y estos desafíos no son en torno solo al tema de salud, sino hay que ser intersección, como se ha mencionado repetidas veces aquí en el panel, de educación, laboral, salud, justicia, ¿no? De trabajo, eliminar la violencia obstétrica, etcétera. Así que tenemos varios desafíos y necesitamos el esfuerzo conjunto de todas las partes para poder sacar adelante este plan de eliminar el estigma y la discriminación. No quiero cerrar sin mencionar algo que sí, no sé, que se ha dicho mucho, pero que falta algo, una herramienta que tiene que ver con el MLC, el monitoreo liderado por la comunidad, y es el tema de los recursos. Los activistas, les activistas, durante 40 años han trabajado con ese gasto de bolsillo, y sí es importante tomar recomendaciones y generar recursos para que este plan de manera conjunta con todas las comunidades, la comunidad indígena, la comunidad que se está movilizando, los migrantes, con las comunidades de las poblaciones clave, trans, trabajadoras sexuales, gay, de manera conjunta lo realicen. Yo hago este llamado, estamos haciendo mesas en los países, tenemos mesas de trabajo consultivo, ¿no? Con todas las mesas, tanto Ecuador, Colombia, Perú y Bolivia, y necesitamos incorporar a Venezuela, que es un país que se nos está quedando atrás. El GCTH, el Grupo de Cooperación Técnica Horizontal, ya ha hecho un compromiso y necesitamos implementar también con ellos y que se sume al plan andino para eliminar el estigma y la discriminación. Nada más con esto quiero cerrar y no dejar de agradecer a todas las partes que han estado aquí. Gracias, Mayerlin, especialmente por esta representación de Redla y a quienes nos acompañaron aquí por el medio virtual. Gracias, Marianela, especialmente.
Gracias, Giselle. Adelante, Marjoline.
Bueno, primero agradecerles a todas, todos y todes por haber estado acompañando este espacio. Me sentí súper recogida en este grupo muy consentida de estos panelistas, pero sobre todo, aunque no nos pusimos de acuerdo, vemos la realidad de maneras muy parecidas. Creo que uno de los grandes desafíos, y un poco Giselle lo menciona, es que los activismos ahora deben fortalecer ejercicios de incidencia política, pero también se deben movilizar recursos para que eso sea efectivo. Es decir, claro, yo seguramente tengo el deber de fortalecer, de visibilizar, de avanzar, pero estas acciones, esto que se han marcado en el monitoreo liderado por la comunidad, porque seguramente eso es también reconocer, y lo digo particularmente desde el tema de las mujeres, es también reconocer que esto es un ejercicio en el que se pone el tiempo y no puede ser que caigamos en el marco del VIH en algo que pasa con las mujeres, y es que se piensa que el cuidado es porque, porque yo soy mujer y debo cuidar, y creo que tampoco puede, digamos, tenerse esta mirada en relación al VIH de, oh, es activista igual, ponga su trabajo, haga y dé respuesta, digamos, como que busque una respuesta que de por sí debería estar. Entonces creo que el gran desafío está en generar acciones de incidencia. Yo me siento particularmente, digamos, desde Bogotá, en un espacio en el que estamos siendo acompañados con ONUCIDA, que me parece que es un excelente ejercicio. Entonces hay que hacer un ejercicio colegiado, acuerpado, pero sobre todo hay que movilizar recursos para poderlo hacer. Muchas gracias a todos, todas y todos. Un
Gracias,
excelente día.
gracias a usted. Doctora Andrea. Jorge, perdón, doctorita, usted va a cerrar con broche de oro. Jorge.
Ya, gracias. Bueno, tampoco oscura mi cámara, creo que no me veo. Ya, bueno, primero que nada, pues agradecer a todos, a todas las personas que se han tomado la molestia y el tiempo para poder participar en este webinar. Creo que son bastantes personas que tenemos por ahí. Y bueno, hay que abordar. Está el seguir trabajando en temas de género, que aún falta. Está el abordaje en jóvenes, el abordaje iniciado. Creo que es vital generar nuevas, fortalecer las alianzas que ya se tiene. Creo que es vital el tema de la academia. Muchas veces las universidades como que no son nuestras aliadas, a pesar de que somos parte de alguna universidad, pero bueno, creo que es importante trabajar eso. Ya lo decía Andrea, que a veces en nuestra formación misma no nos enseñan a no discriminar, pero creo que es importante tratar de transversalizar esos temas, esos aspectos y pues generar sinergias, ¿no? Desde el punto de vista de género, generacional, intersectorial, porque justamente esa interseccionalidad que tiene el estigma, pues requiere también esa multisectorialidad, pero activa, ¿no? No de papel, sino que realmente sea algo efectivo. Y sí es importante abordar ese desafío de los nuevos liderazgos, porque creo que sí hace falta también ese tema, ¿no? Simplemente eso y nuevamente gracias a todos y a ustedes también por darme esta oportunidad de poder mostrar estos números que espero hayan servido de base para generar esta discusión también. Gracias.
Claro que sí, muchas gracias. Adelante, doctora Andrea.
Gracias. Yo voy a ser breve. Solo decirles, años que tenemos ya de saber que no solo somos la región América Latina y Caribe la más desigual del planeta, sino que también tenemos bien claro ahora, tenemos marcos políticos donde ya están establecidos los compromisos, donde los estados ya aceptaron y supuestamente acordaron establecer estrategias específicas para eliminar distintas formas de discriminación. Les presentamos la evidencia. Ya al día de hoy, la fotografía instantánea con una herramienta que es propiedad de las comunidades más afectadas. O sea, esta herramienta es de las comunidades de las personas viviendo con VIH y de las poblaciones clave. Y tiene una estructura y unos indicadores que se han estandarizado. Ya no es la misma herramienta de hace años, que ya no es un tema testimonial, como de alguna manera nos decían frente a los informes del índice de estigma. Es una herramienta que va a permitir en 5 años poder ver qué tendencias hubo, qué cambios hubo y poderlos medir. Tenemos ahora una estrategia específica en el nivel global que nos da la posibilidad de visibilizar en una plataforma cómo va progresando las acciones en función concreta de indicadores que los países tienen que reportar. Ahora tenemos que tomar acción. Listo, ya queda ahora en manos de todos los sectores involucrados que tengamos acción y entonces en realidad yo los desafío a la región andina, a los 4 países, todos los sectores, no se mire solamente el sector salud, a tomar acción específica para que en 5 años, que es el tiempo mínimo para cambios de comportamiento, podamos ver al menos resultados específicos, ¿sí? Que podamos medirlos y que podamos reportarlos. Creo que tenemos, digamos, todos los ingredientes y que ya podemos entonces generar una situación de cambio. Gracias a Lorasconu por convocarnos y por aparte hermanarnos en este esfuerzo y aquí sumando con las comunidades y con los gobiernos, como siempre. Un placer. Gracias.
Muchas gracias a todos y todas, todos. Antes de cerrar a nombre de la doctora María del Carmen Calle, quiero invitarlos para la tarde. Hoy es Día de la Medicina Peruana y va a haber un webinar, Medicina y Salud Pública, Avances y Desafíos. Va a ser a las 5 de la tarde y hay un público que nos sigue. Creo que es importante revalorar la importancia de la medicina y como dijo al inicio la doctora Calle, una medicina centrada en las personas y este es un buen ejemplo. Entonces, a nombre de la doctora María del Carmen Calle Dávila, secretaria ejecutiva del Organismo Andino de Salud, Convenio y Politonal, cerramos este webinar. Muy buenas tardes a todos.
Gracias.